Bismillah ar-Rahman ar-Rahim, my dear vascular colleague, good morning, good afternoon and good evening. I would like to discuss today one of the very important questions that comes in the FRCS vascular exam and European Board of Vascular Surgery. The question is, mention the types of deep venous sterilization, which is a new question because it wasn't 5 or 10 years ago, was not available. So I think you're not required to would have done any of these procedures, but you are required to know the basics of deep venous sterilization. Number one, you need to know the definition. Deep venous arterialization is a technique aimed in providing an option for no option foot or no option except amputation. So this has to be confirmed, and I will discuss how to be sure that this patient is no option patient or no outflow distal target. The aim of deep venous arterialization is to connect a connection between proximal artery as an inflow and distal venous outflow in conjunction with the disruption of venous valve of the foot. And this will permit blood to go into the foot through the venous side. And there is a lot of studies to mention that this will preserve the foot and will have some microvascular advantage to this situation. What is no option foot? You are sometimes asked what is no option CLTI, and this I think one of the best summary with this schedule. The initial presentation is critical limb ischemia, of course, Rutherford between 4 to 6. And this patient have detailed duplex scan to evaluate the plantar arteries that they are occluded. And also diagnostic angiogram mentioned that with distal subtraction, you don't see arteries in the foot, what is called desert foot by Professor Ferraresi. And not also this, but you would have at least one failure of recanalization. So you have tried to do recanalization, but you failed. In some center like Guy's and Thompson's by Dr. Hani, he insisted to have failure twice. So you would have failed twice by the approach. So no one will argue that there is any other option. So after failure of once or twice of traditional vascularization, transfemoral vascularization, they call this disease the end-stage pedal disease or ESPD, which means the foot blood vessel is not there anymore. And this confirmed by ultrasound. So if you have failed twice, you have arteriography and ultrasound documentation that there is no pedal arch vessel, then this is a candidate for percutaneous or open or hybrid deep venous arterialization. So what are the types of deep venous arterialization? There are 3 types. You have either the open type, or you have the closed or percutaneous type. So this is the open type, which is surgery, and this is the percutaneous type, which you do it totally endovascular with disruption valve, or you have the hybrid type. So what is the difference between, which is confusing, the percutaneous and the hybrid type? The hybrid type, you expose the artery, proximal artery, and you take a vein and do anastomosis into the distal vein, and then in the hybrid type you would have destruction of the valve using endovascular valvulotome or balloon or peripheral balloon. So the part which is endovascular is destruction of the valve. So what is the difference between hybrid and between open? You can see open here, you put an inflow graft and you pass with the graft into a venous side. If you done this, valves here will obstruct the blood flow from going into the foot. So you need to have a way of destroying. In the open DVA, this was usually done by metal dilator. So you get a metal dilator and you destroy the valve around this area without any vascular tool. So this is an important difference between open and the hybrid technique. So this is description of the open. You get the most distal good proximal flow and the most distal venous anastomosis you're able to do, and you put a vein graft. Some people done it with PTFE, but you do it with a vein graft. Now, you will be asked about the history of deep venous arterization. Actually, the history goes very old. It's the first who have done deep venous arterization was Francois Franck in performed in 1981. He done it on dogs, and then he done it on humans in 1894. So before this century, deep venous arterization has happened, but the advances was in the development of endovascular. So there is a big company which is called LimeFlow, which have done an endovascular. You can watch the YouTube video on this link if you just search for LimeFlow. Now, the technique is you will have a catheter from the arterial side and catheter from the venous side, and they attach it to each other by magnet, and they have a small amount of radio frequency probe. You can see this is small square there. This radio frequency probe will make like a traumatic fistula between artery and vein. Surprisingly enough, when this happens, you don't get much extravasation. So the blood will travel from here to there. Now after you created this arteriovenous fistula, you need to pass a wire into this area, and then you balloon it and you put a via band. And after you put the via band, you have created arteriovenous fistula. This device by LimeFlow is quite expensive. It's not easy. So came the idea, well, how can we create arteriovenous fistula? You can do that with the total endovascular machine, which is LimeFlow, done totally endovascular, and there is a video about the explanation of the technique, but I will concentrate on how you do it without LimeFlow, what is called off-shelf. Now, in the off-shelf way, you can have four ways. Either you can have double balloon, what is called AV spur technique, and this double balloon technique is important for you to describe. So if we try to describe, you have the artery and you have the vein, and you put a balloon into the artery, a balloon into the vein, and then with the needle puncture from outside, you puncture the balloon exactly like this. So here is the one balloon, and here is the inflated balloon, you can see, and then here is inflated balloon into the venous side. So you go with Sildinger needle. Be very, very important to concentrate on this point. So you go to Sildinger needle, you puncture the first balloon, which is inside the artery, and then you puncture the second balloon. After you puncture the second balloon, then you deflate it. Once it is deflated, then you can pull the wire into the venous end. And this wire is going into the vein through the artery. That is why it's important to puncture the artery first and then go through the vein. Once you have punctured, then this wire, with the deflation of this balloon, the arterial balloon, you can pull this wire up and then you have created arteriovenous fistula. Now, this is the AV spur technique. Now, Yassa has developed a technique. He said, well, it's difficult to do it with balloon. Let us do it with a snare. And this is the idea behind. So you have, this is the arterial snare and this is the venous snare. And both of them have two rings. And you try to put the two rings together. And the main aim is to go with the Sildinger needle through both rings, through the arterial snare and the venous snare with a 21 gauge needle, and then you pass your wire. So if you pull on the snare on the vein, then you get the wire down. If you pull on the snare up, then you get the wire up. Now, after you exteriorize this wire, you put a catheter into the vein, you cross into the artery, and this catheter will have already the connection between artery and vein. This is called double snare technique. We're not sure who has developed it first. Yassa mentioned that he's the first, but also my dearest colleague, Fakhr al-Masri, he mentioned that he is the first to describe this double snare technique. Anyway, it's a technique that you can do it with a double snare. Now, Japanese modification is Nakama modification using guiding caster. We know that they are very skillful, the Japanese, with using the needle, and we all remember the retrograde, the poor man retrograde device by Warasawa. Anyway, this technique is similar. You inflate a balloon, and in the arterial side, you put a caster. And this is a curved caster, look up. And then you puncture with a Sildinger needle the balloon, and then you go into this catheter, and then you pass the wire. So this wire have actually passed Sildinger needle, balloon, then the guiding into the arterial. After that, you go with the retrograde arterial catheter, and then you go into the balloon. This is the Nakama modification to the double snare technique. There is also another technique where you can use the out-back balloon. So if you put a balloon, here is a balloon into the vein, and this is the out-back arterial device, or any retrograde puncture device. You can use Pioneer catheter as well, and then you puncture the balloon. And after that, you pass a wire as if you are passing subintimal dissection. And then once you push the wire into that, you have already created this very nice arteriovenous fistula without the cost of line flow. So this is a quick summary. What you need to know. You need to know the history. You need to know the types. You need to know what is a desert foot, or how you define it and how you proceed. I hope with this quick update, you can answer this question nicely, and you can pass your FRCSVasc exam. I wish you all the best.